Yeah, hi, my name is Sanjay Mukhopadhyay. I'm a lung pathologist in Cleveland. And Matthew, do you want to
Yeah, sure.
introduce
My
yourself?
name is Matt Cicchini. I'm a pathologist here in London, Ontario, Canada.
All right. So the idea behind this whole thing is to have a little discussion, kind of like a car talk, but for lungs. So it'll be
Mhm.
like lung talk, and
Yeah,
we'll
great.
just talk about things in the lungs and thorax. Does that sound good to you, Matt?
That sounds like a lot of fun. Let's do it.
All right. So we are obviously looking at a thymus here.
Oh,
And on the left-hand side, I have a H&E of the thymus. On the right-hand side, I have one of my favorite stains. And I feel a very underappreciated stain, Matt. I don't know if you feel the same way.
I agree.
TDT,
I agree.
underappreciated. Because why I say that is I often get cases, consultation cases of thymomas, where people have done every stain
Yeah.
under the sun except a TDT. And I'm
Yeah.
like, oh man, that would have really helped. It would have helped to have that. All
Yeah.
right, so we're going to talk about this, and I'm going to kind of concentrate on this little doggy face
Nice.
here, and that little doggy face that you have on that. And I feel that it's what you can see even at this mag is that this thing has a dark area and a light area.
Hmm.
And of course, the dark areas are cortex, and the light areas are, how do you say it? Do you call it medulla or medulla? What's the
I call it medulla.
medulla? Okay.
Yeah. What do you call it?
I I don't know. I don't know what I don't know what the right pronunciation is, but
Yeah.
okay, I'll call it medulla like you do. Okay.
Okay. Sounds good.
So these light areas are medulla and the dark areas are cortex. And if I zoom into this area a little bit where the doggy face is, one thing that becomes apparent, at least to me, is that the doggy face areas are the areas with the Hassel's corpuscles.
Yeah. Could you tell us what are Hassel's corpuscles there, Sanjay?
Yeah, so these things are little, I almost think of them as little squamous bits of squamous epithelium because look like squamous epithelium. They stain like squamous epithelium with keratin, CK56, P63, P40. And then as you go closer into it, it really is like a little bit of squamous epithelium
Yeah.
that's become slightly cystic and accumulated a bit of debris inside it. And of course, that varies. Sometimes they look more solid, like these ones in here, but that's what they really are, is little bits of squamous epithelium within the thymus. And that's what the corpuscle is. I don't know, Matt, do you have a little different conceptualization of what these
That's
things are?
exactly how I think of it as well. And these little kind of squamous type islands, I think of like an island in the sun.
Yes, exactly. So let me now bring it to the TDT so you can see the same doggy face in the on the T. So here's the little doggy face there.
Mm.
We're going higher. And you can see in the doggy face that all the TDT is outside the doggy face, right? So it's up there. All these, and the other thing that's important to mention here is that the TDT stains the lymphocytes and not the epithelial cells. So the Hassel's corpuscles, which I am now circling, one of them is not TDT positive. And same thing here. And in fact, the vast majority of cells in the medullary area is not, in the medulla is not TDT positive. There are very few TDT positive lymphocytes. Let me point at one here. Maybe that guy is a TDT positive lymphocyte. So
Hmm.
in general, the normal thymus is divided into a TDT rich cortical portion and the TDT poor but epithelium rich
Yeah.
um, medullary portion, which I find interesting because people kind of try to divide thymomas along these lines, right? So they
Yes.
try to say the B's look more like the cortical portion and
Yeah.
the A's look more like the medullary portion. Any thoughts about that, Matt? Do you like that kind of concept?
Yeah, I think it conceptually works, but I think, as we know in practice, it can be really hard to kind of get things in those categories because there's so much overlap, and I know there can be a lot of challenge and frustration in trying to fit these sometimes square things into round holes and things like that. I think it can be
Yeah.
a challenging endeavor at times.
Is there anything about thymic, histology, thymic architecture that you would like to talk about here?
Yeah,
Or
so I think one thing is at low power, just how much tissue that is here. I think that's important because I assume this is a younger patient,
yes,
given the
a younger patient, child, um,
yeah.
where you would expect the thymus to be still juicy looking instead of atrophic like it is in adults.
Yeah. No, I think that's good. And then I think the other thing I often find useful is that kind of the location of these more medullary areas, that they're kind of more in the central aspects of it,
Yeah.
and they're kind of not really stuck off the periphery. Because I find sometimes the distinction between a B1 thymoma and normal thymus can sometimes be a little bit challenging.
Yep.
And kind of the location of those medullary areas, I find sometimes helps me.
Mm-hmm.
It
Mm-hmm.
is looking at that kind of low power architecture.
Yes, I will say that another thing that strikes me at low mag is it sort of is lobulated, right? Like it's
Yeah,
broken into almost like the lung is broken into
yeah,
lobules by interlobular septa. This thing is too, but the septa are not broad,
exactly.
like they're not broad fibrous septa, and I think that's a useful thing to know
Yeah, they're
in terms of
thin. I
its.
think that's a characteristic thing between thymomas and
Yeah,
between
because
normal.
I look, sometimes the question in difficult, challenging consults is this thymic hyperplasia slash normal thymus versus
Yeah,
thymoma? And I find like the thing that I'm really looking for is the fibrous septa. I mean, I
yeah,
really lean on that heavily as a sign that something is truly
definitely.
a, thymoma versus something else in the differential.
And I think they can be helpful too in small biopsy specimens, right? If you have a small biopsy, but you have a nice area of fibrous septa that you get in that core, I think
Yes.
that can be a really helpful clue that you're dealing with more of a thymoma.
That's true. Also, that these things can be at low magnification, at least sort of mistaken for lymph node tissue with germinal
Yeah,
centers, right? They look like I've
yeah,
seen, at least in frozen section practice, the surgeon comes to you with a rule out parathyroid, and you're
hmm,
about to say, oh, hypercellular parathyroid tissue, and you go, no, this isn't. This is a lymph node,
yeah, yeah,
and you get rid of it, and then somebody comes and tells you, "Oh, that wasn't lymph node, that was thymus,"
yeah,
or
yeah,
you're the one telling them that was thymus.
yeah.
But I find that is a very easy thing to
Mm,
get mistaken. Thymus versus lymph node.
yeah.
And of course, one of my friends, my neighbors actually, Jesse McKinney, once told me that it is a pitfall that you can actually see these things, these Hassel's corpuscles, in what looks like a lymph node background,
Mm.
and then mistake that as a metastatic squamous cell carcinoma and
Oh
think,
yeah,
yeah, that's really true. If
yeah,
you
definitely.
didn't have it, the context, you could clearly go down the tubes on this. You might think this little squamous nest is malignant, and why else would be epithelium be in a lymphoid background?
Yeah.
So it's really worth thinking about that.
That's a great point. And I think maybe it's worthwhile talking about some reasons why the a patient might have a normal thymus taken out.
Yeah. Well, one reason that I see commonly in practice is that, at least in children, is Down syndrome. I find
Mm,
that is a thing that Down syndrome children are having cardiac surgery, for
yeah,
cardiac valvular abnormalities. And then they have this thymus, relatively big thymus, and they take those out for some reason. I'm
yeah,
not sure exactly why.
okay,
Those get taken out. Thymuses that are enlarged for
yeah,
any reason get taken out, if they're incidentally enlarged, or surgeons, while doing a thoracic surgery or some sort of cardiac or cardiovascular surgery, notice an enlarged thymus and tend to take them out. But to me, that is in children the more common reason. I have to
yeah,
say that I don't see a lot of pediatric surgery. So
yeah.
for me, this is not a common thing. I don't know, Matt, what do you think are the common reasons for?
Yeah, we don't see a ton of them either, other than incidental things. In an older population, we do see them for myasthenia gravis, taking out the thymic tissue, whether it's normal or hyperplastic or a thymoma,
Yes.
kind of along that spectrum. We do see also cardiac surgery in older people too, when they'll take out a bit of tissue that's kind of in the surgical path that'll end up being normal thymic tissue, but it's much more atrophic than this.
Yep. Oh, can I mention one thing here, Matt,
Of
which
course, yeah.
I was reading it yesterday, and I thought it was fascinating.
Mm,
It's actually very, very basic, but I thought it's still worth
yeah,
mentioning here. I was reading a really nice review article in the COVID. It was about COVID, but it was
mm,
talking about immunity in general, it just immune cells and immunity in general. And one thing they talked about was why T cells and B cells are called T cells and B cells.
no,
Right? So the
cool.
B cells comes from the bursa fabricis, which is the bone marrow equivalent.
Yeah.
Um, but the T cells are actually named after the thymus.
Oh, interesting.
Yeah, so the T is as thymic cells,
Oh, cool.
and it's because the thymus is where the T cells do
Yeah,
all their, the complex
yeah,
thing of whether a T cell is self-recognizing and needs to get
yeah,
weeded out, or is a true, is recognizing true foreign antigens and needs to be kept. I think all that complex immunity happens in the thymus.
Yeah. When I
And
was in,
so underlying all this, fascinating architecture is even more fascinating,
yeah.
biology, which of course we don't see on a light microscopic level, but there's a lot going on here in this organ.
Yeah, when I was in medical school, they taught us that the thymus was the T cell university, and that's it's where the the T cells went for their higher education. So
That's
it's
right.
that's the
That's
way I've
right.
always remembered it.
That's right. I think it's worth pointing out here once before we stop this section
Yeah,
is that this thymus is typical of a child,
yeah,
and the younger the child, the more likely you're likely to have a normal thymus like this. But as time goes by, this thymic tissue disappears
hmm,
and all that's left is little, pieces at the edges. And those pieces are really very atrophic in the sense that
yeah,
the lymphoid and epithelial structures are very little is left of them, and what's left is really adipose tissue.
yeah,
So you've got big hunks of adipose tissue with very small pieces of like true thymus, which is
yeah.
called atrophic thymic tissue. And if you practice in an adult setting like mine, mostly seeing
Mm.
adult patients, you'll never see this kind of thymus in your
Oh,
practice.
it's
You'll
true.
only
Yeah,
see atrophic thymus, right? So
yeah.
that's maybe during one of our subsequent sessions we'll show atrophic thymus and what that looks like.
That makes. And then if a clinician asked if this was like true thymic hyperplasia, maybe we can just discuss how we would sort that out in this case.
Yes, great point. So true thymic hyperplasia, I'll tell you, Matt, the funny thing is that's one of the few reasons that I have an AFIP fascicle on the mediastinum
Yeah,
is
me too.
because is the AFIP fascicle on
Yeah,
mediastinum has a table,
yeah,
and that table has thymic weights in it.
yeah,
And that's really the only thing I ever
yeah.
use it for,
Me
is
too.
that table is so helpful because it gives you the range of normal thymic weights for a particular
Yeah,
age. So let's say this was, I don't know, 13 or 14, you would look in there and say for an age range of 10 to 15, the normal range is 75 to 100, let's say.
yeah,
And let's say this one was 150, you'd say, oh, this is too much weight,
yeah.
that this is too heavy of a thymus for this age, and that would qualify for true thymic hyperplasia. So what it is essentially is histologically normal thymus, but just
Yeah.
heavier than usual, or more of the thymus than is usual for that age. So you really need to know the weight, and that's why weights are so important when
Yeah.
you're grossing in thymic specimens.
How do you approach cases where you don't have the weight? Like if you got a case in consultation that unfortunately the weight wasn't recorded.
Yeah, that is a
I know
tough
it's a tough
question.
situation, and I don't really have a good answer for that either. Because
Yeah,
really without the weight, it's not really in the cases I've had. It's been you can raise it, but you can't really
confirm
classify
it.
it.
Yeah, I agree with that. I guess the thing you can do is bring it up and
Yeah,
say that if this were exceeding the normal weight,
yeah,
this would be true thymic hyperplasia. But if it doesn't, it's benign, normal thymus. Either way, it's benign.
yeah.
So maybe that's the way to bottom line it.
No, that's a great point.
Yeah. Yeah.
I think this is a great first start of the case, and maybe we'll
Yeah.
keep going on the next ones.
Great idea, Matt.